Good morning, everyone, and welcome to this event from BEUC, the European Consumers Organisation, which is looking into the European health data space. The title of the event being Use or Abuse of Consumers' Health Data. We're going to have about an hour and 45 minutes discussion about what the European health data space proposals mean for consumers, for researchers, for the politicians that are working on this proposal going forward, and we've got pretty much every angle that needs to be covered of people who are going to be speaking to us about this. So I'm delighted to be asked to host this. My name is Jack Parrick. I'm a Brussels-based news correspondent working predominantly for the German public broadcaster DW News, also a few British newspapers and some other publications as well, and I have a focus on consumer and business issues oftentimes. So I'm really excited to get into this discussion. It's something that I personally am very interested in. So just to explain how the event is going to work a little bit, we're going to have a presentation from BEUC about the results of a survey into how consumers feel about their data being used, their health data specifically. I won't go into the details of that because there's people that are much more preferable to explain all of that to you. And then afterwards, we're going to have a general discussion about the results of the survey and what it all means. It's really, really interesting what they've been looking into. And then we're going to have a discussion about the primary use of data, so my data being used across borders. So if I, as a Belgian resident, were to have my health data used in Spain for my own health, and then we're going to move on to a discussion about secondary health data, which is more all of our data collectively being put into databases and able to be used for research and to investigate diseases, etc. And what that means, what the challenges around data protection, how consumers feel about that, how citizens feel about it themselves. Throughout the discussion, we're going to have possibilities for a Q&A, and that's going to mean that you can ask your questions to the panelists. You can drop them into the chat and they will be fed through to me. It'd be really, really useful if you could say who your question is directed towards so that I can make sure that that person is the person that's going to be asked to answer the question. Now, if you're tweeting or if you're talking about this event online, then please use the hashtag consumer debate or the hashtag EHDS for European Health Data Space. And that means that we'll be able to follow and join the conversation and continue it after the event takes place. So, I mean, the idea of this is to try and look at the merits of the proposal around the European health data space, weigh it up, see what needs to be tweaked, see what needs to be changed. And so let's get into it. The first thing that we're going to do is hear from, excuse me, from BEUC's Director General, Monique Goyens, who's going to just outline a little bit why this survey was put together and what exactly, where we are on this proposal at the moment. So Monique, delighted to see you this morning, and I'll just hand you the floor.
Yes, thank you very much, Jack, and thank you very much to the panelists for being here and for the audience for also participating into this conversation. Let me give you a few minutes, a helicopter view about why we have been organizing this debate. You know, Europeans have a reputation worldwide of being champions of personal data protection, at least on paper. And the most symbolic personal data is health data. It is about our bodies. It's about our lives. It's a huge element of our vulnerability if those data are being disclosed against our will. So in any initiative that handles health data, one better gets the personal data protection aspects right. But on the other hand, when we speak about health data, on the other side of the spectrum, we also have to understand that health data, if they are well designed and well used, are a public treasure because they contribute, if being well processed, to better public health care, which is good for the people, which is good for the healthcare system, and which is good for society. So healthy people means a healthy society. So it is really important to get the two aspects well together. And we are at a crucial moment indeed when it comes to health data in Europe, because health data are being discussed by the EU institutions under the context, under the umbrella of European health data space. And in fact, European Commission has published last year a proposal on the creation of a European health data space, which is in fact a single market for accessing and sharing data of people across the European Union. And this is good because currently there is quite a lot of fragmentation going on, and depending on where you live in Europe, your data is not, your health data are not being handled in the same way. And in fact, the proposal, and Jack already referred to that, distinguishes between two types of users. First, the primary use, which is, can I share my health data, or are my health data shared with what health professionals in what country? And the second is the secondary use, meaning that how are anonymized or pseudonymized data being used for scientific research or for public health purposes within the European Union. And in fact, the benefits of creating such a European cross-border health data space are tremendous, but there are also downsides. And what our impression was when reading the proposal of the Commission is the people are going to give away health data, but have they really been asked how they want this to be happening? And we thought that there have been maybe not enough space being given to the people to explain how they see how their data should be shared. And that is why we organized this survey. So together with 8 of our member organizations, we surveyed across the European Union more than 8,000 consumers, and we really asked them, what type of health data do you wish to share with what type of stakeholders for what purpose? And the survey, the results are really quite interesting, and my colleague Sylvia is going to give you more details about that in a few minutes. But this survey also provided us with insights about how people feel, I mean, the need of trust that they need to have in the healthcare professionals so that they are ready to share those data. And what is for us crucial is it is not too late. Currently, the institutions are discussing the European health data space and the boundaries of what is allowed and what is not allowed. And we believe that for this health data space to be a success, it needs to take into account the expectations of people when it comes to how their data are being handled. And that's why we are happy to be able to feed into the institutional conversation by the results of our survey. And now, Jack, if you agree, maybe Sylvia could provide a little bit more details of the figures. And I look very much forward to the panel discussions in a few moments. Thanks a lot.
Yeah, thanks so much, Monique. And Monique will be joining us on the panel to discuss this further later on in the coming moments. But as she said, we're going to hear from Sylvia Maurer, who has been putting this survey together. She's going to explain a little bit about BEUC's thinking behind this, why this survey was put together, and what the policy recommendations that could come out of it are. So Sylvia, welcome. Thank you so much for doing this for us this morning.
Good morning, ladies and gentlemen. Jack, can you see my presentation now in the presentation mode? Yes.
I can see it. Yeah.
Very good. Yes, good morning. As Monique just pointed out, we have been reaching out to consumers in Belgium, the Czech Republic, France, Germany, Greece, Italy, Spain, and Portugal, so a little bit all across the EU, to find out what data related to their health they would be willing to share, for what purposes, and with whom. We have also asked them a little bit about what are their attitudes on how they would like to manage consent, and are they actually aware of their national situation with regarding to e-health and electronic health records, and the whole discussion about the European health data space. We also wanted to find out more about their trust levels related to different institutions and with whom would they share the health data in confidence. And what are their views about the benefits and concerns related to the creation of such a health data space. It is already today the fact that many people are using health platforms with a very high rate in France and a lower rate in Germany. But at the same time, it doesn't mean that people are super confident of sharing their health data, and that many people would have have the feeling of having control over their data, and not everybody, for example, has also changed the settings or would know how to do that if they are using such platforms. So not everybody knows also how to protect the privacy, even if people are not feeling so confident about it. So actually, what we found in the responses is that the people are very selective about what kind of health data they are willing to share, and that there is a huge discrepancy in relation to the level of whom they trust to give that health data and with whom they would not share that data. And a lot of people also said that they want more actively be able to choose what happens to their health data, and they prefer to give explicit consent to that. When it comes to the attitudes of whether or not they see it beneficial to share cross-border health data for primary users, such, for example, if somebody from Finland travels to Spain to see a doctor, there were like mixed results, and it was a little bit half-half, where a lot of people saw benefits, but also a lot of people just didn't see the need to share such data. And I can only give you a snapshot. The report is publicly available. There are some graphs. I just put here one or two out of them, where you can see that also the type of information that people would be willing to share is very much differing. So about their current health status and data, a lot of people would give that for care purposes to their doctors. But then when it goes down to share some genetic data or information about reproductive health, it's like getting very low. And also people do not in general want to share information about their health habits, for example. There are also differences, as I said, with whom people have trust and whom they would hand over such data. So in general, there are a lot of people who would be willing to give that to their general practitioner to improve their health care. But it already goes down then when you look into other entities, like be it emergency room doctors, and it goes even further down when you look into research or other healthcare professionals. And of course, if you go even further down to look into like insurance companies or like wellness app developers, there's really only very little people who would like to give away such data. So our conclusion is the further you go away from the general practitioner, the less trust also people have in sharing that data, because they probably don't really know what it is being used for and what happens to the data. We had also asked then people about what they see as benefits and concerns about health data sharing. And there were indeed also a lot of people who believe that the data sharing can lead to the development of new or better diagnostic systems and easier access to treatment across the European Union. But a lot of people also had the feeling, apparently, that if already they are giving away their data and somebody else is doing some development with it, it should somehow be reflected in more affordable and more accessible healthcare services and in medicines. The survey at the same time also showed that many people have great concerns related to data theft or unauthorized access, or that somebody could just misuse such health data. Maybe just 1-2 words about what were our conclusions from the research, because obviously this is very important for the ongoing political debate in Council and European Parliament on what kind of legal rules will be set at the end. We have been pointing out that we believe for the primary purposes, so meaning sharing for healthcare purposes data, there should be an opt-in mechanism with very granular settings for patients so that they can choose the data that they want to share and how and with whom. We do not believe that everybody should automatically be included in the health data space without being asked for consent. And for the secondary users, so meaning for public health care and for research, we would say that there should be at least an opt-out mechanism for the secondary purposes, and that you need to put additional safeguards in the legislation. That means that some types of data should completely be excluded, such as genetic data, for example, or person-generated data from wellness or other digital apps. But there should also be some purposes being restricted for the secondary users. We are quite concerned that that it's not foreseen for the moment to have an independent check that the software which is being used cannot be hacked or being used very easily by cyber criminals. That's really a point of concern. So that's also one of our recommendations, that the legislature normally should do better to give also people confidence that their data cannot be stolen. But as there were also a lot of media reports in recent months about the fact that cyber criminals have already accessed health data that is electronically available in some data spaces, that there must be a right to compensation for consumers, and that also it should be possible to allow for collective representative action in case there are big cases where data has been stolen, disclosed in the internet. Also, as I said, there are a lot of people who believe that there should be some return if they hand over their data, and that's true for really 68% of the respondents. I would say if you are interested in the data collection, take a look in the report. We thank very much EURO Consumers for having helped across the EU with the data collection, as well as our members. If you have questions, don't hesitate to come back to BEUC, to the health and the digital team, and we are very happy to have a dialogue with you and to answer your questions.
Thank you so much, Sylvia. Really, really interesting, and actually really important at the moment to be doing this kind of work right now, so that we can understand exactly what people are thinking about this right at this moment, where it's the idea of the health data space is starting to sort of formulate itself. It's super, super useful to know exactly what's going on. So thanks so much to Sylvia for outlining that for us. Really appreciate it. So now we're going to move on to our panel and get into the discussion around this, around the issues that Sylvia has raised there. And to that end, we have a really great panel. I'm delighted to introduce Fulvia Raffaelli, who is from DG Sante, leading in the digital health unit from the European Commission, obviously. We have Maria Roubtsova, who is an economist and the health policy officer at UFC-Que Choisir, which is the French Consumers Association. We also have Sara, a senior policy officer at the Standing Committee of European Doctors. So really, really good to hear the other side. I mean, how doctors are going to use this, what benefits this sort of data can be for them. We have Petar Vitanov, who's an MEP, a member of the S&D group. Delighted that he's here with us. Dr. George Veliotes, who's the chairman of Insurance Europe's health platform, is also joining us, and Monique Goyens is going to stay with us to continue the discussion around this. So thanks everyone for being here. Really appreciate it. We're going to start with you, Fulvia. The European Commission's proposal came out, a few months ago. Can you outline what's it about, and can you explain whether the survey of the results, what Sylvia's just been outlining there, maybe contradicts what the Commission's put forward?
Well, good morning, everybody, and thank you, of course, for the invitation. It's always a pleasure for me to be part of this conversation. I think this is very important occasion and opportunities that we have to explain and to actually look together at the risks, but also at the benefits that the proposal is bringing forward. So indeed, the proposal looks at the two legs that also been looked at into the survey. So the primary use, meaning the use of health data that is done directly by the patient. And then the secondary use, which is the collective use of those data for innovation, for long-term benefits and societal benefits altogether. I don't think, frankly speaking, that the results from your survey contradict. So there is no opposition. There are, of course, a point of attentions and areas which are highlighted. Let me first focus on primary use. So the use of health data for the interest of the patient itself. What we see from the survey is that there is a strong interest from the patient perspective to have a control on their health data. And this is exactly what we are also foreseen in the regulation. We are very conscious that trust is key for the HDS and for its success. And therefore, we have really included the highest possible cybersecurity and privacy standards into the regulation. We have safeguards on the access to data. So we actually foresee that electronic data will be for each of us, for each of the patients that we are, but also of the healthy person that we are, it would be possible actually to control and even to restrict the access to their own health data in case they don't want to share a specific event of the health history with the practitioners or with the health professionals. So we also have foreseen a mechanism to actually trace who access the data and why. This is of course very important from a patient perspective. Is also important for the doctors, for the healthcare professionals themselves, to improve the possibility of early diagnosis, of cross-checking information. So the fact that those data would be available and accessible, of course, upon need, let's say, when needed, to a broader range of professionals is of help for the patient itself. We know the proposal as such, and based on the division of tasks, let's say, a responsibility between member states and the European level, the proposal is focusing on the cross-border exchange of data, meaning that gives to each one of us the possibility to access data also when in a different member states. This is for treatment reasons, or of course for traveling reasons, but it also aims, of course, to facilitate the access to data within the member states. Although this is under the full responsibility of the member states, we believe that actually by setting standards for the exchange of data at the European level, this would also improve the situation within the member states. And we know that this is a problem for the, I mean, as an expert, I have faced already many times this big challenge between of exchanges data between the patch. So all in all, we consider really that by setting the highest, let's say, level of safeguards for the data, we are actually improving, as of today, the rights that the patients can access on their health electronic data, going exactly in the direction of the survey you just shared with us.
Thanks so much, Fulvia. Interesting outline. I mean, there's a broad acceptance that lots can be done, but there are concerns still about exactly how this will play out, and I suppose that's why this conversation is interesting right now. I'm going to come to you, Petar. I wonder if you can explain a bit about what you think of the proposal, whether there is scope for abuse of this system in any sense, or whether you think already what's on the line is protecting consumers, presumably not fully, right?
Yeah, thank you. First, I would like to thank you for this invitation. This is extremely important file, and of course, it's not only health legislation, but it's also digital legislation, including extremely sensitive information, which is private data. And of course, there are several potential risks associated with the use and abuse of consumers' health data. Maybe I will point out just some of them. First, when it comes to privacy and security risk. Of course, the proposal itself aims to improve access to health data while maintaining data protection and privacy. But however, there is always a risk that personal data could be mishandled or improperly accessed, leading to breaches in privacy and security. Especially when it comes to secondary use of health data, this should only happen under strict conditions. The applicant should clearly state the purpose of which the data will be used and how it will be handled, and of course stored. Because look, as a human being myself, I do feel uncomfortable knowing my most sensitive data could be exposed. And if I were to agree to it, it will be because I feel there is a shared public interest which should outweigh the risks. And when it comes to primary use, patients' life cannot be always fully exposed, even to their physician. Because think about simply the even more sensitive data, such as linked with the sexual and reproductive health. Also, the other risk is linked with the discrimination, because this health data can be used to discriminate against individuals based on their health status, for instance, such as denying them insurance or even employment opportunities. And I'm really confused why the Commission felt no need to include in the categories of data to be shared things like educational level or occupational insurance status or some other things, which are far away from curing the cancer, for example. Another risk is linked with the lack of transparency and control. Consumers may not have the adequate control over how their health data is being used. And I noticed during the survey that this is one of the concerns. This lack of transparency and control could erode trust in the healthcare system and discourage individuals from seeking care. It's not entirely clear how the different national systems would work with each other and how we are going to ensure that people's data does not end up for objective reasons. Of course, another risk is linked with the inaccuracy and bias. Health data can be subject to errors and bias, which could lead to inaccurate diagnosis or treatment decisions. And this could happen if data is shared across borders with different healthcare systems and cultural contexts. And even now, it's so obvious and it's so clear that access to healthcare is not equal throughout the European Union, and even within a single member state. Those that are really marginalized people, vulnerable families, they risk even more exclusion. And maybe to mitigate this risk, the European health data space must include strict data protection and privacy rules, as well as provisions for transparency, accountability, and consumers' control over their data. And maybe one final risk, this is not linked with the abuse of this private data, but it's the fact that this piece of legislation requires a lot of money. And I think that maybe some countries, they do not have the money to implement those systems in their national healthcare system. So I expect this ambitious piece of legislation to be stopped or to be limited to some extent because of the lack of the money in the some national budgets, and this would become maybe obvious during the council's meetings and council's negotiations. Thank you.
It's going to be really interesting when the countries start getting a hold of this, for sure, Petar, as well. Just to say that point that you brought up about educational level being involved, I'm actually, Fulvia, I will put that question to you when we've heard from some of the other panelists as well about to explain why that was decided to be in there. We'll talk about that in a little bit more, but I'll turn now to Maria Roubtsova. We heard in Sylvia's outline that French consumers have been pretty up for sharing their health data so far and using apps, etc. Can you explain a little bit about why that is, and also about the reception of the French system? Why, I mean, if we're saying that collecting data is good, why has it been successful in France?
So when you look at what platforms French people are using the most, Mostly they use the Social Security website, which you have to access to track all the refunding of your healthcare acts, and also to fix appointments. So what is the most similar to the European health data space is what we have in terms of electronic health record. And it's not among the most used platforms at the moment. So I'm going to elaborate most on that because that's what we have in France that's similar to the EU project. So from 2011 to 2022, we had an opt-in system to have an electronic health record. And since 2022, we switched to an opt-out system. So for 11 years, only 10% of people chose actively to open an electronic health record. And since it became an opt-out system last year, only 5% of people refused to open this electronic health record. So one key difference between what we have in France and the EU project is that here it's only for health professionals. So there is absolutely no sharing of the data with third parties. And in terms of how consumers reacted to this system opening for everyone last year, mostly people can see the potential benefits in terms of having access to their health records, regardless of which practitioner you go to, so you don't lose paper documents. But consumers are skeptical that their electronic health record is kind of empty. That's because, well, first of all, healthcare professionals have little time, so they don't have more time to fill in more documents. And there are projects to change the informatics system of healthcare professionals to make it automatic for them to enter the data in the online platform. But the development of those programs is kind of late. So that's why they're not filling everything automatically at the moment. And also, I think the main concern of French consumers is the potential data theft, because we had a couple major problems like COVID test results that were leaked online, people who received results of other people with some personal data. And also we had some hospitals that got hijacked and some criminals were asking for a ransom in exchange of not leaking the data. So I think that's why people are concerned about that. That's where we are right now.
Yeah, really, really interesting. Thanks for outlining that for us, Maria. Appreciate it. Because, yeah, I mean, to see where and how it works and also how it's being protected, it's all about trust, isn't it? And if you feel that it's you feel that your data is not really in the right hands, you get worried. We're going to turn on to Sara Roda now, who's from the Standing Committee of European Doctors, because let's be honest, all of this data is only useful if you guys, you doctors, can use it or make use of it in some sense. What's the importance of the European health data space, this legislation, for doctors in practical situations, but also in a more overarching sense, Sara?
Well, thank you for the question, and thank you also for the invitation to be here. For us, indeed, this is quite a revolutionary legislation that is being proposed, ambitious, also very positive. But there is also, of course, and I will focus on those areas where it is a little bit more problematic, because these are the ones that we think need to be worked further. And one point, because it has been a little bit touched upon, and one of our key points that we are making is that doctors should be excluded from the secondary use of health data and the secondary use of regime. And this because tensions are rising as there are direct conflict rights in the proposal. So on one side, we have this absolute right to request data to health data access bodies by applicants. And on the other side, you have privacy and medical confidentiality, the right to control your health data, but only in primary use and not in secondary use. So there is these direct conflict rights, and it's not solved properly. And we have doing a little bit of a deep dive in terms of medical confidentiality. How is this being perceived or not? And indeed, if we look and we put a little bit past on legal basis and having a legal basis to share data, which would be the HDS. If we look at the initial purpose of collection for the doctor, so the doctor is collecting for treatment and purposes, and then you would be required to share for secondary use. So this is not really entirely what was expected and the expectation of a patient, which is indeed the expectation of a patient-doctor relationship in a confidential way. So this is also not under the reasonable expectation of patients to share. Really a key point, and other safeguards that would need to be in place about the proportionality and necessity. So all the data that MEP Vitanov has mentioned is indeed beyond what is proportionate and necessary in some areas. So we also look into the medical liability in the legislation, and so we feel that this is not so much clarified, and we would like to have some certainty in that regard. So if patients do block certain information from doctors, if there is a lot of data and the doctors are not able to see everything, and also the risks of manipulating the file. And so, as also it was mentioned, there can be inaccuracies in the file. So you cannot take the file as the truth stone. So we really think that health professionals should only be responsible for the data they have collected and insert them themselves, and so they cannot be responsible for the quality of the data in electronic health record that are originally stored by other health professionals. So this should be, we believe, in the legislation. We also feel, and we agree with BEUC on the third-party conformity assessment part. So the electronic health records really need to be checked upon by a third entity. We see that this can be, and we understand the debate about the medical devices regulation, how complicated this has been, but maybe there can be other mechanisms that could be streamlined or be creative. And I could also give some hints on that. Also, that the connection with certified apps in the legislation, this should be also a requirement, involve more ethics committees in the secondary use. So this is also not talked so much, how the evaluations of data requests will be made. And for us, we think the way forward, because every healthcare systems are very fragmented. In the EU, we need to have a flexible approach in the secondary use. So it's very hard to have this top-down imposition. And so for us, it would be really needs to be decided at member states level, respecting their traditions and cultures, what would be the approach, and also in relation to the types of data that are required.
Really interesting. I mean, it's so complicated, but also important. And I think you've really outlined some of the delicacies there and some of the needs for this to be really well thought out before it ever gets into place. So we're going to turn now to Dr. George Veliotes, who's from Insurance Europe. But I mean, health insurance is super important, obviously. What do health insurers want? As much data as possible, no? You're muted still, George.
Good morning, everyone. Thank you for the opportunity and the invitation to provide some input into this very important topic. It is a privilege and an honor for us to be here and to be able to give this input. Just at the outset to say that if you look across Europe, there's no two countries that have the same health systems or the same insurance systems to a large extent. There's a lot of variety, but in most countries, you have a mix between private and public provision and insurance in many instances. But data is at the core of the insurance business, because insurance processes data to analyze the risks that individuals want to take in order to cover their needs and to tailor the products accordingly. So it's very much at the heart of the insurance business. Insurance works on the principle of risk pooling, on risk-based underwriting. In other words, evaluating, assessing the risk and pricing it in a fair and proper way. And the risk is based on the relevant information about the person applying for the insurance, and therefore the decision to insure to price is based on whether and how the insurance applicant provides information relevant to the risk that the insurer takes. Based on that information, insurers are able to assess the risk accurately and to come up with a fair pricing and to be competitive in the market as much as possible in order to cover for consumer risks. There is strict legislation as well in the form of Solvency II, the Solvency II directive, and the provisions where insurers are obliged to prove that they use solid and up-to-date data sets with sufficient historical information to assess the characteristics of the underlying risks and to identify the trends in the risks. So inherent in the insurance business is the propensity to select and anti-select. So often what one sees is that people are more prone to require some coverage, have a greater need to acquire insurance, and this can create an imbalance. So average premiums, if you don't have the ability to match the price with the risk, then what this could lead to is very high premiums, and people would then not be able to afford those very high premiums, apart from the individuals that have a desperate need, where in many instances they would sacrifice a lot of other factors or needs to buy that insurance, or alternatively, the cover would be diminished for all consumers. So the additional cost by having a very high price would actually leave out a lot of consumers from good insurance coverage. Yeah. And only people with the highest risks would therefore have the need to buy expensive coverage. It would become, I think, overall less attractive to insurers, and even very unaffordable, and leaving a lot of people with less coverage in the population. So it will create a major distortion if one intervenes in the basic fundamental principles of insurance, which is risk-based underwriting. And we think that it is very important to keep that principle intact under all circumstances.
Thanks, George. That was really interesting. We'll pick up on some of those points shortly, though, because obviously, all health needs to be paid for essentially at the end of the day, and that's what the insurance is there for all of us. I'm going to come back to you, Petar, because I know that you've got to go soon, right? You've got to get to the airport, I think. So I just want to it would be great to get a sense from you, specifically on the primary use of data. What's your opinion about where the current proposal, what needs to be amended in it? What will you in the European Parliament be pushing for when this, as this goes over your desk?
Several things. I would say the first one, it was already mentioned, the European health record systems. Sara mentioned it, also BEUC mentioned it in the beginning in the survey. Those systems should undergo a third-party conformity assessment. A regime of self-certification as suggested by the Commission is definitely not acceptable. We had the similar situation with the deployers of AI systems in the previous legislative file concerning the AI that I mentioned in a private conversation with you before the beginning of this session. So the other thing, people should retain the right not to disclose certain information to their doctors. For instance, we are in Poland today, and if a Polish woman gets an abortion in Germany, she should have the right to keep this information private, including also from the Polish authorities. Even the fact that there is a restricted information should remain private. And of course, to specify what kind of data, health data could and should be shared for both primary and secondary use. We have to limit the possibility for Commission to expand the list of data via implementing or delegated acts. The categories of data should be listed in the operative part of the regulation by co-legislators. And maybe finally, the issue with the phone health applications. We have to try to limit the health data. We don't need to pollute it with the low quality data, the one we used in our phones or watches. We have to limit the scope of the data as well, so that in order to make sure that we have really health data with high quality, and also to avoid the inequality, because in some countries these applications are very often used, in some countries they are not. Some people cannot afford to buy such applications, some people can. So the quality of data must be also the focus of this legislation as well.
Yeah, thanks, Petar. I hope that you'll stay around with us to the last moment. Maybe we can come back to you.
Maybe 15, 20 more minutes. So.
Okay, I'll try and get back to you in a minute then, if you can. But if not, thanks so much for joining us. I certainly will. We're going to move on. We're going to move back to Sara now, because the use and sort of filling in of electronic health records, super consuming process for healthcare practitioners. And to sort of make sure that the boxes are ticked, that every medical consultation is done. Does this, you know, when you're there with your doctor, what do you want? You need a personal relationship with them. I wonder if you can explain what that does to that relationship as well.
Yes, indeed. So the electronic health records, and there is the digitization of the healthcare, can dehumanize the profession. So this has been written a lot in academia. And so there are certain things that doctors have to do to try to adjust it. But the problem, as it was raised, the interface that the doctor will have and how usable will that be can alter everything from frustrations to someone being not efficient and not able to see all the patients that are supposed to see in that day because the system is down, is not working. Or if you need to go to advance on the questions, you always need to click on that little box before, or you don't want to ask that question. And so even the development of certain cognitive skills may be diminished because you are conditioned to a specific questionnaire. So you have to pay attention to that. You also may seem that if you have, for example, a drop-down menu, all the symptoms or diseases do not entirely qualify to what you are expected. So it is indeed a lot easier to access to the data that has been put into the system, but it is quite consuming to put data into the system. So things also cannot work as intended. And we think, and the information that we had, for example, in Denmark, there had been at least a 20% of reduction of productivity with the introduction of the electronic health record. So this was really quite astonishing with all the administrative work, and many tasks that the doctor were not doing, he started doing because of that. So one of the things that doctors would like to work better, but it's not so well, is speech recognition to be embedded in the electronic health records, to have 3D human body where they can easily access and see how it does, the use of symbols and icons. So these are all things. But indeed, the patient-doctor relationship will change. We will have, for example, the I-patient, the E-patient, so the patient, the doctor, and the digitized patient. And we see that with this legislation, the medical confidentiality will be shaken with this. So we have to be cautious on safeguarding the patient-doctor relationship in this regard.
Yeah, it's so interesting, isn't it? Because it's fundamental to everything. And if that drops, then, and if people are nervous about what their doctors are doing, then the whole thing is completely pointless from the start. So just to remind everyone, we're talking about primary data, the use of primary data now. So the data that we use ourselves, about ourselves, that is given to different doctors, and if we wanted to cross borders, how that would be used. And for everybody that's joining and watching this event, we're having a super interesting discussion, but we'd also love to hear from you as well. So feel free to drop your questions or your comments into the chat, whether you think the proposal that the Commission's put forward is good, whether it works for primary data, whether there needs to be amendments. Any comments, any questions, anything that you'd like to ask any of the panelists, please feel free to drop them in, and we'll get around to that in a short moment. But we'll go back to Monique from BEUC. Do you think the Commission's got it right on primary data?
Well, before I answer that question, I would just like to respond to George on insurances, because the insurance industry has been doing quite well without access to health data. And now, I mean, if you go and personalize your risk, it's the end of the concept of insurance, because insurance is about mutualization of risk. So if you only insure those who are not really a high risk, what's the risk for the industry? So I'm really very much afraid of what has been presented there as being a really at high risk of not only high prices for some people, but also exclusion from insurance. So this is a major danger that we are in fact calling out of a collection of health data by insurance companies. And that's when you saw the figures of our survey, the insurance companies scored very low in trust of consumers when it came to share the data, just so that you know. So now, sorry, I'm coming back to your question, Jack.
Yeah, no. It was fascinating. I really agree with you there, Monique. Yeah.
Now, our survey is quite clear. More than half of consumers want to share their data with, so for primary use, so with healthcare professionals, only after explicit consent. And they want to have really granular settings of the type of controls they can access. Now, the Commission indeed has provided for safeguards, but they provide for a default inclusion of you into the healthcare system, into the healthcare space. And it's not just a stupid change of name, opt-in versus opt-out. If you compare those two concepts with behavioral economics, you know that when people need to opt out, they just don't do it. And that's the figures that Maria also shared from France. So that means that the control that you have in an opt-in system is much more important, behaviorally speaking, than an opt-out system where most people are not even aware that they can opt out. I'm from Belgium. I have been integrated into the health platform without me knowing who has access, and I'm an educated consumer, I think. So this is somewhere, and I don't even know how I can opt out. So it is very, very difficult. So we really believe that the Commission proposes a system that needs to be reversed, because also the settings that can be adjusted by the consumer under the opt-out system proposed are quite limited. So, for example, what we see from the survey is that people have different levels of trust into different levels of, with regard to different types of healthcare professionals. Highest level is with the healthcare, with your physician, with your general practitioner. They don't want so much to share their health data with the pharmacist, for example. So this needs to be able, they need to be able to put that setting, that this is not provided for, if I have read well the proposal. Also, there is no system put in place to raise awareness of consumers about what they can do, what are the choices available. And there really needs to be a stepping up of, if consumers are part of that conversation, they need to be given the tools. And Peter said it, what resources are going to be used for that? It's really important to have consumers on board in a well-informed way. We also believe that the system needs to take account which type of health data can be refused by the consumer. And as Peter again mentioned, people are quite okay to share their general health status, you know, am I in good health? But everything which is related to reproductive data or sexual data, health data, are really like a no-go zone for many people. So it's really very important to take that into account. Also, the whole system is going to be managed by delegated acts by the Commission. So the Commission is going to decide what type of priority categories are going to be part of the health data space, and how can the consumer opt and make choices if those choices are not certain and if they can move over time. So we really would like the system to be much more consumer-centric, meaning that it should be an opt-in system where people explicitly give their consent to share data, and it should be granular, meaning that people should have the choice to say, I'm sharing this type of data with this type of healthcare professional.
Yeah. So I think the next person we have to go to now is Fulvia to explain this a little bit. So this is it. There's this sense that perhaps the Commission is going to take control, move the goalposts, do delegated acts, change the system, That idea that the education that Petar was bringing in, the idea that sort of not all the data that we might want to share is already being included in this. What's your response to that?
Well, thank you very much. This is fascinating, and I'm very happy to be here today, maybe to explain it again, because what I feel from the overall conversation is that there is still a bit of confusion, or at least not a clear distinctions between the primary use, which is made, as I said from the beginning, in the only interest of the patient, and then the secondary use. These are two completely different areas, because in primary use, we are speaking about personal data. So indeed, this is sharing my data, Fulvia Raffaelli, with my practitioner, with other healthcare professional, but it's only in my interest. Okay, so I'm sharing my personal data are sharing with another, my dermatologist, or I don't know what, only if it is in the interest of my treatment and in my care. If there are no need, let's say, to access my data, then those data will remain where they are. And this is quite clear in the Commission proposal. Cross-border exchange of those data only happen on the request of another healthcare because of my interest. So if I have an accident or if I'm treated in a different member states, there are no other options where those data will travel. And I heard many times that in your introduction, actually, the patients and the consumer in general don't agree to give away the data. But I think this is really giving a false image of the fact of what we're doing with the data. There's no open bar. Nobody can access the data without authorization, or we're not really creating a system where data are made private data are made public.
Do you accept, though, that here the language perhaps in the proposal is just not clear enough then at the moment? Because at the moment the sense is that it can be changed and that it can be used in other ways that perhaps we haven't originally given our consent for.
Sorry, it's not. Let me say, okay, everything that can be done to clarify, we're very welcome. We're listening, of course. We're looking at the hundreds of amendments have been put forward in the Parliament, the changes which have been discussed in the Council. So everything that can be done to clarify the proposal is, of course, welcome, and look at that with a lot of attention. But let me just still on primary, and I want to be very clear that I am on primary. The concept of opting in primary use, frankly speaking, it's a bit of a strange concept. And here I would like also to hear from Sara, maybe, because this is about basically not having my data registered in an electronic way even in the general practitioner file, because this is somehow normal practice today to have my data registered, at least in the health record systems at the general practitioner level. So frankly speaking, this looks a bit strange concept to me. And an opt-out.
Let's Sara answer that.
Yes, so indeed, in terms of the question that at least has been discussed in the past, it's also about digital dissidents. So people that do not want to be part of the system, if there is a place for them and do not want to have the electronic health record, we accommodate that. But even in terms of practical terms, if every general practitioner is electronically is using electronic health records, no. So the system in the European Union is very fragmented. You have countries that are very very developed and have electronic health record system, but they are working on their own, and it's not connected with a network or anything else. And then you have other systems where they still work on paper. So I have the pediatrician of my own kids, they only have paper, and the GP in Belgium also only works with paper. And you have others that in a hospital where everything is integrated and can be shared. But even when it is in a hospital setting, at least in Belgium, it's not everything goes to the electronic health record. And as Monique was saying, indeed, no one asked if we wanted to have or not the electronic health record. Of course, it's very useful. And from a patient point of view, it's very useful to have these data at hand, and we don't forget documents, and also for healthcare professionals. But well, we need to try to accommodate other parts. And maybe I just can also add a point that I wanted to forget about the secure transfers that, for example, data holders would have to do under the secondary use regime. So to make it clear in the secondary use regime, if health professionals would be obliged to share this data under the secondary use regime, it's not so clear for us how this transfer would be done, how the data would be prepared, or if the doctor is spending time, which we think they should not because of the shortage of healthcare professionals, of the data that should be shared with the health data access body, how is supposed to do this in practice, and IT personnel involved, because we don't talk a lot about the IT personnel, many cyber attacks, rogue employees, the architect of the system is all done by people, humans, and they're IT, so they are crucial people in the system. We don't talk a lot about them. And so also if the doctor spends all the time preparing the data, they say the price that would there be, and then on the other side, this is too expensive, we are not interested. So they had done all that work for nothing. So there you go.
Yeah. Thanks, Sara. Monique, you've got your hand up. If anyone else on the panel, if something comes up, this is actually a good thing to do. You can pop your hand up and I can bring you in. Monique, go ahead.
Yes, thank you very much. I just wanted to respond to what Fulvia was saying. I think that this is indeed, how do you work in explicit consent with the GP? And in fact, it is indeed that type of ecosystem that needs to be created. Our survey showed that people trust most their doctor. And so if that doctor can be the entry point to create the trust into the health data system by explaining, I know healthcare professionals are under huge pressure and they have a lot of administrative tasks, but they are the entry point. They need to explain to the patient what is in it for them. But you need at least that entry point to get that explicit consent. And then they can still decide later or at that moment that they only want to have this privileged relationship with their GP or with others, but they should be able to do that with an informed consent procedure, because for the moment it's just where it exists, it's often just ticking a box or it's out. So we need to invest in the trust relationship. That's the price to pay to have the health data space people-centric. And that means a little bit of time to get people into it with the explicit consent. I mean, this is just my 5 cents to the discussion, if I may.
Yeah, no. I think this is one of those, it's such a thing on this where we have these discussions in Brussels about all these sort of perfect discussions and way legislation should be worded and stuff. But unless it's all of the 450,000+ people in the EU are like, yeah, I trust the EU to do this, then it just doesn't work. Fulvia, I can see you've got your hand up. I mean, there's going to be big bust-ups in the council as well. I know we'd like to ask you about that, whether you think that all countries are going to be on board, but perhaps you can come in and respond to something that you want to respond to as well.
Yes, sorry, just a point on this opt-in, because I mean, I understand this consent-based, etc., but I also understand, I mean, wonder, and I think I very much agree with you that information about the system would be crucial to create trust. This I 100% with all of you to make really clear what we're speaking about, because I understand also the digital, let's say being afraid of being in the system, but I wonder if this person is also afraid the moment, what would be the reaction the moment the person is sick and is going to another practitioner, and then the other practitioner will find an empty EHR systems. And that's, it's something you don't think all the time when being, in full health. So I think there is also something that where we really need to educate the patients and the consumers again about the use that is possible. I'm still in primary, yeah, so I'm remaining very much in primary. What we see in the council, actually, it's a lot of questions still, so a lot of investigation on the details, so a lot of really practicalities, asking, going down to the details, which is very important, because at the end of the day, member states will be the one deciding in the way they're going to organize their health systems. You know, the European Union has no competence into it. So many of the details actually that you referred to, Sara and Monique, will be defined not at our level, but at the national level, in particular, the interface for the general practitioner. This will not be defined at the European level. It's only the interoperability objectives, which is the technical elements of it, that would be defined by us, and the security elements. This will be set at our level. But then anything else, so in terms of feeling an interface, this will be very much in the hands of the member states. Also to define if it's going to be the general practitioners to buy and to decide which one he wants on the market, or if they will be filled by national administration. So this would be very much in the hands of the member states, and we fully respect that responsibility. So this is something member states are very attached on, and try to understand really what they need to do to help them make it happening. And the other points again on primary is the third-party certification, which has been mentioned already by several points. Of course, we're listening to it. We try to strike a balance between the fact that this is a very innovative process and would somehow to be phased in. Also from a manufacturer perspective, that we have not much experience in that, and so the manageability of the whole system, and the fact that indeed we need to foresee the EHR systems which are fully reliable for the client. So on third-party certification, as I said, we again very listening with a lot of attention to the member states. This is one important point, and we'll try to find the solution.
Yeah. So we're going to start bringing in some questions. Claude Popard talked about he asked whether collecting data, they asked whether, but making data usable is another. Oh, I see Maria Roubtsova's answered that in the chat. So if you go into the Q&A, you can read her answer, which is super interesting. Thanks for doing that, Maria, because we're running down on time. So let's move on to Thomas Hellebrand's question, who asked about the impact assessment. In Annex 11 of the proposal, states that the European health record system should not be subject. Sorry, I've just lost the question there. Should not be subject to third-party assessment because they don't pursue a medical purpose. Do the panelists agree? Does anyone want to come in on that? Perhaps Fulvia, is that something that you can answer?
I mean, I just mentioned our vision on the health, so on the third-party certification of EHR systems. These are systems to record, so as such, they do not qualify as medical devices. So medical devices are subject to a different legislation, and we fully respect that. So as such, the systems are recording the data and not and somehow of course elaborating the data but not producing data as such. So as I said, I mean, this is a point that we are discussing with the member states and with the parliament, and what we need to, the objective is to ensure that there is a full trust on the reliability of the systems. Maybe I can say also a few words on words on the wellness hub, because it has also been mentioned many times. The idea here is that what we have suggested is that only the well app that claim interoperability, so not all well app, it's a choice of the consumer again to buy an app that is claiming interoperability, and then we would expect them to be done only if you want to share the data. If you don't want to share the data, then you buy an app which is not interoperable and you're safe. So I think this is also something that needs to be somehow understood. And data which comes from a wellness app will be flagged as such, so not to be confused with data that comes from healthcare practitioners of methods.
Yeah, thanks, Fulvia. We're running a bit out of time, so that question on structured and unstructured data, I said Maria's answered it really interestingly in the chat. So if you're joining the event and you'd like that question, I'd advise you to have a look at her answer. Super interesting. But Sara, just before we move on to secondary data, I can see your hand raised.
It was just because for the question that had been made on the impact assessment. So if it is indeed a data protection impact assessment, I think that it should be conducted because electronic health records will move with a lot of data. So there needs to be a mapping of the kind of data that they will hold and who will have access and all these kind of procedures. So in my view, a data protection impact assessment should always be required. I can also just mention a little bit about the blocking of data, because this has been touched upon. And of course, we understand on the reasons of the need to block certain data from healthcare professionals, but because this can be a little bit something that the doctors are quite keen to know and have access to the information that they require in order to properly treat the patient. We just highlight that indeed medicines and allergies is quite important information that doctors need to know. So this would be a challenge, not having access to this information. And because of blocking certain information, there might be need that certain procedures would need to be done extra. So wasting time and resources in doing evaluations to reassess things because they are not certain, making then less time to again treat patients, or if there is because of longer procedures, the patient is not treated in time because they need to check certain things. So there is always this little counterbalance on what kind of things we should block, but maybe this will be done at member state level, as Fulvia has mentioned. Thank you.
Yeah, thanks, Sara. Now we're gonna move on to secondary data. Just I'm aware of the time, so we'll push the conversation on. I think we could continue on this for the rest of the whole event, but we'll move on to talk about the use of secondary data, and we'll start with you, George. Just to remind everyone that the primary use of data is my data for my health professional. So in my service, secondary is all of our data used by other parties to research or to understand more about diseases or to understand more about what's going on. So generally, we're all, as we heard in the survey, we're obviously less inclined to give our very personal data away in this sense. We're going to come to you, George. I think probably you'll want to pick up a little bit on what Monique raised before. But obviously, when I'm getting my health insurance, my own health data is significant to the insurer that's going to insure me. But what does secondary data mean for your industry, for your business?
Thank you, Jack. Firstly, to just say that we welcome the Commission's proposal on the primary use of data. With regards to the secondary use of data, I think one must, the vantage point from the insurance point of view is that insurers are there to provide coverage on as much as possible inclusivity basis. Our objective is to reach as many people as possible and to counter the let's say the elements of exclusion. So that's the overall objective. To do that, though, we need to have a sustainable and balanced and fairly priced system where, as I said earlier on, you need proper risk pooling and basic principles to make that sustainable and viable. I think one of the things that is important also to emphasize that ultimately all these initiatives are for the benefit of the consumer. The consumer is our customer, and whatever we do is actually to benefit the consumer. So medicine though is changing very rapidly, and the knowledge, let's say, curve is multiplying at an exponential rate, and in a year you can have a doubling of knowledge, specifically in certain conditions like oncology and other neurological diseases. Today, over 50% of expenditure in insurance systems in many countries is for chronic diseases. And it's things like diabetes, it's hypertension, it's asthma, etc., where these conditions afflict a big part of the population, typically an aging population. And there's a very important role for prevention, be it primary prevention or secondary prevention, to firstly prevent these conditions from manifesting through primary screening and early intervention, but also for individuals that are afflicted by these conditions through secondary prevention measures to allow for early or proper lifestyle modification, dietary modification, etc., to prevent unnecessary complications from settling in. And ultimately, the objective is to have better quality of life and lower costs, both for the consumer, but also for the insurer that is managing that risk. So having access to anonymized health data is a critical component for insurers to be able to get access to some data for risk monitoring purposes, and also for the development of innovative and creative and new coverages. It's not a static situation. It's a very dynamic and changing situation. The health needs of people and the coverage that the insurers gave 10, 15 years ago is completely different to the needs of today. And we need to, as insurers, keep abreast of these developments in order to fulfill the underlying needs of our customers. So we've seen some significant progress in conditions like, for instance, HIV and AIDS, where a few years back, those conditions were almost considered to be terminal, where today, with new advances in medicine, new treatment methods, and new prevention, let's say, initiatives, people can lead almost a normal life in many, many instances. And these cases are increasingly becoming cases that today can still be insured. So I think the access to anonymized secondary data is very important for population health management, for chronic diseases, and for the development of innovative and new healthcare solutions. Of course, it will also assist insurers through benchmarking, through the use with other AI applications, to be more efficient in the claims management things and the claims handling, to speed up the payment and settlement of claims, but also to prevent an unwanted and unnecessary wastage in the claims process, either through fraud or other means. So the secondary data is a very important aspect for insurers. And coming to Monique's comment about the insurers, I think one must draw the distinction between discrimination and differentiating fairly between risks, because I think insurance is about differentiating fairly between the risks and treating different risks differently. It's not about discrimination, it's actually about inclusion, and it's about pricing in a proper manner. So it's the mechanism to avoid moral hazard and adverse selection, which is inherent in the risk pooling. And as I said, the objective is for us to enhance and to broaden the coverage to more people and have less exclusions in this process. But it needs to be fair and balanced.
Yeah, thanks, George. Just reminding our audience that you can drop questions on this as we continue. We'll, as we have the discussion on secondary health data, I can already see some questions coming in. We'll put to the panelists at the end, but feel free to continue to write those questions, and we'll get to as many as we can. So I'm going to turn now to you, Maria. In France, you've got pharma companies, tech companies, insurance companies. They've all got the right to the access of the data through this French data hub that you were talking about. What's the debate on secondary use of data? Sorry, they've got the right. What's the debate going on in a member state, and a big member state, no less?
Yes, so currently, no, there is absolutely no secondary use of data in the public shared electronic health record. However, some companies are buying some health data from hospitals, for example. So it's kind of operating in a legal gray area. So maybe if that secondary use was done through the centralized system, it could be better framed and limited by the law and more transparent. So we have kind of a decentralized system, and some companies manage to get their hands on the data, and maybe on some aspects they develop very useful products. So currently it's kind of two completely separate areas. So on the one hand, we have a health record that is only for primary use, and on the other hand, we have secondary use of health data, but completely in an anarchic and decentralized manner. And there is not really a debate, but that's as similar as the absence of public debate on privacy issues. I don't think France is a very privacy concerned country compared to other countries. So people are kind of worried, but also they are mostly worried about their data being stolen, for example. So it's more of a misuse of primary use. And I think the general population is not really aware of a secondary use of their data in general, and not only of health data. And we as a consumer organization, we try to raise awareness about what companies collect in terms of data and what they do with it. But I'd say we are at the beginning of trying to create a public debate on the subject. So it's not really central right now.
Interesting. Thanks, Maria. So we're going to turn now back to you, Fulvia. The survey results basically show that there's a low willingness for people to share their health data. You know, they're not really involved in, especially for ones that aren't involved in direct provisions, and yet there is no opt-out for secondary health data in the proposal. If a data is involved, then it's in and we give it away. I know you didn't like that phrase when I used it earlier, but I mean, that's kind of what it is, right? If we don't have the choice, that's how it works. In that sense, is there consumer choice? Does it respect our choices?
Well, thank you for recalling. In fact, that I don't really like this concept of giving away, because this is confusing. Well, first of all, it's not my Fulvia Raffaelli, my personal data, which was given away, as you mentioned, because it's only data which are anonymized or pseudonymized, so are collective data. And I like it the way you explained the difference between primary and secondary use. In secondary use, indeed, we're speaking about the collective use of our data, and there is in the regulation there is a specific provisions prohibiting re-identification of the patient. So I want to be very precise. Secondary use is not about the use of personal data. It's about data which have been preventively anonymized or pseudonymized in first place. Second, is not an open bar, so it's not true that anybody or for whatever uses so you can access this data. There's a very long, actually, and precise process that goes from the applicants then to the actual health HTAP, so the national bodies which are in the position to decide yes or no this data can be accessed. And in the requests, we're taking into account all the principles which are set in the GDPR on one side, but also on the Data Act about minimization. So you need to explain why do you need that data, for which use, and really what kind of safety guards are you putting in place to respect and to protect the use of this data. And those measures are, frankly speaking, much more strict than the most of the one you have in place today in many member states where there is no regulation about secondary use of data. And this, of course, there are a few member states where this is up and running, and everybody's going to those countries to get their innovative ideas tested. Because the reality is this one: is that today these secondary data are regulated horizontally in a handful of member states today. And these are the places where actually most of the most innovative research are taking place. So if we want, this is secondary use, our approach has been to establish very strict and precise rules for the access of our collective data to avoid any personal re-identification and all possibilities to, and setting actually the purpose and the prohibited uses and all the safeguards the same for everybody. The moment you're going for an opt-out or even an opt-in, you go in granular to the position or to the let's say for the decisions of each one of us, which of course is playing a very important role, but it needs also to be counterbalanced with the benefits. And I understand that here we're focusing more on the problems, but I would like to spend a few words on the benefits that we expect from the use of data in secondary use. It's about the treatment for each one of us, because again, when I'm healthy, I don't care about the treatment. When I'm sick, I want to be used for me the most innovative and perform a treatment and medicines. So this you can only have access, you can only receive if there is research and innovation ongoing, and this is based on data. This is been made very clear by all certain research centers, medical authorities, EMEA. It's not only about pharma companies. And I think we need to keep that very clear in mind. We're speaking about benefits for the whole society in the longer term.
Yeah, I mean, there's no question that sort of more data helps. I mean, that's not the sort of disputed fact, but it's how it's collected and what's happening and how it's used and whether we get a choice around it or whether we can change our decision afterwards. Monique, for you, do you think there should be opt-ins, opt-outs of secondary health data? I don't mean your own, I mean sort of everyone. Oh, well, your own as well. I mean, I suppose that's important too.
I really think that we need to have there a balanced approach. We fully acknowledge that sharing those data for secondary uses can have a major benefit for society, for scientific research, for public health purposes, as long as people are properly protected and that there is still choice. This is really the balanced approach that we want to see. And what we would like to see is at least an opt-out system for secondary use of data. And there should be additional safeguards. And I saw some questions in the Q&A there. And what are the safeguards that we would like to see built into the legislation there? First of all, exclusion, very straightforward, exclusion of anything genetic data. Genetic data cannot be anonymized, because you find it's proper to one single person. So that is something that is very important for us. We also believe that should be excluded from the scope behavioral determinants of health. The way you live, or also data that have been collected from medical devices and from wellness apps, because there might be much too much, room for interpretation or for mistakes. We also believe that certain types of secondary uses should be restricted. For example, it should not be just a broad purpose. It should be really very specific. Could not only say something like for personalized healthcare as a justification to have access to the data, or for innovation. Healthcare open access to secondary use of data should be something that should be done for healthcare purposes or for public health purposes, not for enhancing business profit. This is really very important. This should not become a commercial hub. And also, some users, once you have received access to those data, some users should not be allowed. For example, no advertising, no marketing with the results of the health data. So there should be really a much stricter frame around that. What we also believe, because anonymization I agree. Pseudonymized data, I cannot say that word correctly. So they are in fact personal data. So GDPR applies. It's personal data. Anonymized data, there should be huge quality requirements on how do you do that. You do that because you can be very vulnerable, and people can end up being still re-identified. So it's very important. And there that we have maybe not really mentioned this today, but what is very important is that the health data access, yes, that's right, health data access bodies, so those who are really monitoring the way the system is going to be performed at national level, really are given the resources to monitor, to provide control, and certainly when it comes to quality requirements of anonymized data. And coming back to those bodies, what is also very important is that the system really is like based on the precautionary principle, meaning that there is one of the provisions in the proposal is to say like administrative silence, that if the health the bodies do not respond, then the secondary use is allowed. This is something that should not be. You should have the people first and then the business after. And this is something where we believe, Peter mentioned, it's very important that the whole system is sufficiently resourced, not only with financial resources, but also with the staff that can follow and play the role as watchdog again, in order to have enhance the trust that people will have into the framework. Jack, I was a little bit afraid that you were lost because the charger was low. So I hope you're still there.
Sorry, yeah, my battery just popped out. Apologies. Thanks for filling in, Monique. I'm really sorry. I missed the end of what you were saying as I was switching the batteries through. Thanks everyone for bearing with me. Interesting, yeah. So you picked up on some of the questions that we were going to come to, though. Synonymized data from an anonymous attendee, a very interesting sort of meta thing that we've entered there. But really good to bring in those questions, and I think it's really interesting. Thanks for doing that, Monique. That saves us time in the Q&A. But reminding everyone that you can continue to pop your questions in there should you want to. I'm going to come to you, George, especially after the Greek-sourced words that we've just brought in. The survey that BEUC did shows that there's quite an extreme lack of trust in insurance. Not extreme, but like it's clear lack of trust in insurers when it comes to secondary data. What would you say, sort of adding limits or bans to the use of certain data that consumers don't want to share? I mean, what's your feelings about that?
Thank you for that, Jack. I think from an insurance point of view, adding bans or limits on the data could stifle innovation and prevent the creation of new innovative health solutions. I think also that what we are seeing more and more is that the insurance or the funding part is becoming a very integral part of the whole healthcare delivery system. And there are more and more integrated models that are emerging to bring, let's say, the funding closer to the provision of care. So whilst the survey shows that consumers have a low willingness to share this health data with industries not involved in the direct provision of healthcare, insurers, I believe, and we believe, are key for the healthcare system. Because in most countries, most of the funding of healthcare providers is through insurers, be they public or private insurers. So it is important, though, to emphasize that consumers should always be in control of their data. They should be able to choose which data they wish to share, with whom they want to, and for which purpose. And in that context, it is also very important to safeguard the consumer's ownership of the data and to ensure that the data sharing is consent-based. Consumers should always be aware of what data they're sharing and for which purpose. Given the sensitive nature of the health data, there should always be appropriate safeguards, technical safeguards, and in principles, the health data shared under the should be anonymized by using the highest possible technical standards. In that context, we are actually disappointed with Article 35, which proposes to prevent insurers to use newly available health data, because fundamentally we think that will hamper the development the keeping up to new medical developments of insurers, and by extension, it will have a negative impact on consumers and the industry at large. As the data, though, should, and in our opinion, should always be anonymized, the prohibition is not necessary, since anonymized data cannot be used for decision against a natural person. It's also important to emphasize that the insurance industry is a heavily regulated industry with robust EU financial services frameworks in place, where you have, for instance, the IDD, which is very strictly, let's say, supervised as well, but also very importantly, the Solvency II directive, which establishes very strict requirements and criteria for supervision for data accuracy and quality requirements. So overall, we believe that insurance is an integral part of the healthcare delivery. It's important for the insurers to be able to keep up to speed with the developments in the medical advancement journey, but the customers and the consumers should always be in control of their data. In that context, also, we agree that they should have the option to opt in and to opt out, and that they should be firmly in control of that decision.
Thanks, George. Yeah, so now we're going to move on. Just before we get to the Q&A, we're going to have a little sort of round robin of one question, same thing to all of our panelists. And what I want to ask is, where do you think the legislation can go wrong? What can be problematic as we go forward? I think we'll start with you, Sara. In just a short answer, what is the biggest problem that can divert this legislation from working?
For us, it can be if indeed obliges to violate legal obligations of professional secrecy and medical confidentiality rules, especially in the secondary use regime, and not clarifying medical liability under the primary use regime.
Short and sweet, very clear. And I think that, I mean, it's an understandable perspective from a medical point of view as well, and fundamental, like you've outlined throughout this discussion. The trust and the feeling that your doctor is there for you is just so important. Maria, I'll come to you next. Same question.
So I think the main risk is that there is no actual public debate, because that's political. Like, the question is, how much privacy are we willing to forego in order to improve some things, and what things? For example, do people really want insurance companies to get access to their data? Or do people really want their genetic data to be shared? So I think we need to have a clear debate about what consumers have to gain from it. And I think the risk is that we don't have this debate. People don't really get interested in the topic. And then people just get used to sharing everything, and we just lose a lot of privacy for uncertain benefits.
Yeah, so it's an interesting point. So from your point of view, the legislation, if it's not clear exactly where the data is being used and where the benefits are, then it's not really serving its purpose then. Okay, we'll move on to you, Fulvia. I mean, I suppose for you, the proposal is fundamental, but what can really hinder this legislation from your point of view?
Three short points. First of all, that the negotiations take too long, and then we don't manage to close it. That this is a problem mainly because of the ongoing, actually, digitalization at member states level. So this is ongoing. The process is ongoing, and the more we wait, the more we face divergent systems than creating different conditions for patients across Europe. So this is it's a matter not of Commission ticking the box, but it's really about creating a EU objectives that would then allow convergence, let's say, amongst the member states. Second point is that we overcomplicate the situation, so that at the end we created another monster, as we unfortunately have a few already at the European level, which is not then implemented afterwards. And this is a second big risk that we need to keep in mind. And then the third, I would say, is that instead of creating trust, this creates mistrust about, and the resources are not sufficient either from a human resources perspective or financial resources, then to make it happen in practice and to provide the benefits that we all expect as as a citizens first, and then before then as a patient. So these are the three big risks from my perspective, and for that we really need to work together and focusing on the benefits in the medium long term.
These are common Brussels legislation issues, pretty much, that a lot of legislation needs to face, especially divisions among member states. Hey, so we'll turn to you, George. For you, what do you think is the biggest potential for downfall in the legislation?
Well, I think for Article 34, we propose that a new paragraph be introduced to allow for so that one can analyze the general trends and the patterns of the health status of the population and to develop competitive tariff for insurance products. And secondly, also to delete Article 35, which would forbid insurers to request and to assess reused health data for the purpose of modifying insurance premiums. Because this data will be anonymized, this prohibition, in our opinion, is not necessary and cannot be used for decisions against the natural person. I think what is also important, though, is that the guidelines and the standards of anonymization need to be clearly defined.
Yeah, thanks, George. I think that's an interesting point. Monique, we'll come to you finally before we take a couple of questions from the audience. We are slightly running out of time, but there are some interesting questions that we'll get to. Monique, what's the biggest potential problem with this legislation?
For me, the potential problem, and I'm a little bit responding to Fulvia there, I think it should not be rushed through the mill. We need to take the time. If you want to have trust, you really need to take the time to integrate the public debate, to integrate the concerns by people, because you don't only look at the European health data space. People are starting to get fed up by being just a bunch of data, not only in the health space, but in the commercial space. People are resigned, people are frustrated. You really need to get that right. I think it has a major potential, but if the trust is not there, and if the concerns by the people are being overlooked, this is not going to succeed. So please, I would say, take the time, quality over speed, because at the end of the day, the result will be better.
I think it's so true. I think just in the sort of digitalized world, especially that we live in, you know, when I go to my doctor, I probably just want my doctor to feel like a doctor, not, you know, and I don't want to feel that I'm constantly a data point. I think everyone feels that. That isn't to say that data isn't useful and shouldn't be used, but I think there's much to be said for that. So there's a question. I mean, I'll start with the one that's directed to you, Maria. France has set up the French Health Data Hub. The question is that not used to get access to some set health data for secondary data use? You did touch on that, but I mean, it could easily be adapted to, right?
Yeah, so on the one hand, we have Mon Espace Santé, so my health space. That's the thing that now 95% of people have, and which is run by the Social Security and which allows for no secondary use. And then the Health Data Hub, it's not run by the Social Security, and it doesn't have everyone's data. It's run mostly by research, public organizations. So it's a separate platform entirely. And they do use data for developing new treatments. But right now, the two are very disconnected. And I feel like the European proposal is looking more like Mon Espace Santé, which is the Social Security one, because it's opt-out based and it includes primary use.
Yeah, so, but all of this can be changed and adapted. I mean, if the legislation works out, everything can be moved. This isn't, we're not working in, you know, one area, and once the legislation is sort of ironed out, it's clear. Honestly, like, this is a really good question, but it's dangerous. I feel like it's a thing that we could talk for the whole day on, but I'll bring it in and I'll see if anyone's interested. The question is, it has been said that the platform should not be commercially used, but why not? Why not let people sell their data if they want? I wonder, Fulvia, if you can come in on that, and then if anyone else is interested to bring in, because it was all to all panelists, you can put your hand up.
I mean, indeed, it's a good question, but maybe this is really to be addressed to each one of us. I mean, with the commercial use of my own data, this is not prohibited as such. So you still, I mean, the system would be in place, but we're not foreseeing that use at that possibility at collective level. And I think this is very important. So it outlines the fact that the uses we are foreseeing are all uses which are as an objective, the one of providing a collective benefits to groups, of course, to group of patients and when needed, but also to support actually long-term, medium and long-term policy, horizontal policies. I mean, I don't need to refer back to the COVID crisis, but if you would have had in place the EHD at that time, frankly speaking, reactions and the identification of possible solutions would have been much quicker and maybe early done. I mean, so this is really what we have in mind when designing the second benefits. And of course, we cannot, companies as pharma companies cannot be excluded from the system, because at the end, a lot of innovation comes from pharma companies. We need to strike a balance, of course, in between commercial objectives of the pharma and actually real true support to the innovative treatments and medicine products. But this is the fact. I mean, that much of the innovation in treatments, it comes from them. So it is about setting the right safeguards. I'm very happy, Monique, that you were actually at the end. Your suggestions are very constructive, if I hear you well. So thank you,
Monique.
Yes, just to say, I mean, the EHS is about giving away your data, and why not? But what we see in our survey is that people say that they are happy to share their data for scientific purposes, but they would also like to see this reflected in the price of medicines. So, I mean, solidarity goes both ways. And we have another survey, but also research going on, which shows how difficult sometimes it is to have affordable medicine. So, I mean, EHS also feeds into that conversation, which is, if data are being shared, there should be a return on that investment. But that's another conversation.
Exactly. You should have with member states more than with us, unfortunately. So.
Yeah, there's so much. I feel like I don't want to stop this event. I feel like I want to go on. There's so many more interesting aspects that we could bring in, and so many. There's been some interesting questions in the chat, but unfortunately we're out of time, and I know that everybody will have other things that they need to go on in their day. I would encourage everybody though to search the panelists out, look at their organizations. The details are on the invite. And if you have any questions or want to reach out to people, I mean, that's kind of the point of this events like this, is just to start, continue and forward the discussions. So reach out to the panelists independently if you want to have a conversation with them. But thank you so much. I really, really want to thank all of our panelists. So Fulvia Raffaelli from the European Commission, to Maria Roubtsova from the French Consumers Association, Sara Roda, who's given us a really interesting perspective from the medical side of things, to Petar Vitanov, who had to leave us a little bit earlier, the S&D MEP, but brought in some really interesting angles, to George Veliotes, who's the chairman of Insurance Europe's health platform, and to Monique, obviously, and as well to Sylvia, who ran down that the results of the survey, which is very interesting and is available on the BEUC website. For more information, definitely go there. Thanks so much to all of you, and thanks so much to the panelists, to everyone that's joined and watched as well. It's been a really interesting conversation. You can continue it on social medias using the hashtags, which are Consumer Debate and EHDS. A huge thanks to BEUC for having me to moderate this session. It's been really interesting, and I look forward to continuing these discussions. Have a great rest of your morning.